Hey guys, it's again me. It's Vikram Deshpande, one of your favorite bone pathologists, and I'm here to quickly go over two additional fibroosseous lesions, fibrous dysplasia and osteofibrous dysplasia. Right off the bat, here is an image that is typical for fibrous dysplasia, and the buzzword that you're going to learn right now is fibrous dysplasia shows this ground glass appearance. Ground glass appearance. There you have it. All right, let's get the demographic stuff right out of the way. Let's start with fibrous dysplasia. This is seen large in both adults and children. The polyostotic, when multiple bones are involved, that's referred to as polyostotic fibrous dysplasia. Polyostotic fibrous dysplasia is detected more often in children, which makes sense. When it involves a single bone, the term there used is monoostotic fibrous dysplasia, and then it is detected in both adults and children, but more often in adults. It affects both genders. There are certain sites where you see it often, the head and neck area, in the pelvis and the femur, but you could see it in virtually any bone. There is really no bone that is spared of this disease. Now the imaging appearance, particularly the on plain films, is very typical. You take this to a radiologist and they'll tell you what it is without you even having to prompt them. Here it is involving the neck of the femur, another good site for the disease. And I'd like to point out a couple of things. One is, notice how sclerotic the rim of this lesion is. That generally indicates a benign process, so that should make you sleep better at night. But look at the interior of this lesion. It has that fine white appearance that is referred to as ground glass. That's created by the calcification within the lesion, and that's very typical for fibrous dysplasia. This was a resection for polyostotic fibrous dysplasia involving more than one bone. You'll notice it's involving the metatarsal and tarsal bones. It looks whitish, but another very important feature to recognize is, notice it does not extend beyond the cortex, so the bone is intact. There's nothing in the soft tissue, and it's not really changed the shape of the bones very much. So it's all of that speaks for a more benign process. Of course, you will very rarely see a resection specimen. For the most part, as with most benign tumors, you will see curettage specimens, if at all. Remember, a lot of cases of fibrous dysplasia are never biopsied because the radiologic appearance is so typical of the disease. All right, so this is classic fibrous dysplasia, but I have a very low power view to remind you that, now this is the cortical bone, to remind you that this lesion does not extend through the cortical bone into the soft tissue. Only a malignant process tends to do that, right? So this is confined to the bone, an important rule to remember. Very classic low power view. Every time I show this to one of my residents, they'll go, snap, this is fibrous dysplasia. And what they're looking for is these curvilinear fragments of bone surrounded by relatively hypocellular stroma. Nevertheless, stroma, and I say hypocellular because it looks very pink. If it looked blue at this power, I would worry. These are supposed to look like Chinese characters, but they don't. Apparently, they don't quite look like Chinese characters. Here you go again, fragments of bone. Some of them are mineralized, and they tend to be somewhat curvilinear. Again, that relatively hypocellular spindle-shaped stroma that is better seen at this magnification. All right, so now we get a better look at our bony trabeculae and the spindle-shaped cells in the stroma. Notice that the bony trabeculae are lined by cells, but these cells do not look like osteoblasts. By definition, you should not have a very prominent osteoblastic rimming. You may see an occasional osteoclast. And when you look at these stromal cells, It's a relatively hypocellular lesion, and there's virtually no pleomorphism, no atypia, no mitotic activity. Occasionally, you might see these bony fragments that look like cementum or samoma bodies. Does that matter? Not a bit. Again, notice that there isn't much of an osteoblastic rimming. A feature that you'll often see in fibrous dysplasia is fairly well described here. These fibers that connect the connective tissue of the lesion to the bone. Do you see these things? These are referred to as Sharpie's fibers, and they are fairly typical of fibrous dysplasia as well. What if you don't see them? Oh well, nothing can be done. It's still fibrous dysplasia. It's now time for us to play You May See This in Fibrous Dysplasia. You remember the game? Every entity, there are features that are classic. Then there are features that you may see. And then finally, remember, we end up with these are features you do not see. So let's start with you may see this in fibrous dysplasia. And the first feature you may see in fibrous dysplasia is cystic fibrous dysplasia. This is a T1 MRI. This is a T2 MRI. And all these bright regions right here are cystic. So you can see a bulk of this lesion in the neck of the femur is cystic. And this was the curettage I received from our surgeons, and you can see there are three very distinct looking areas. One that looks typical for fibrous dysplasia, right? You can make that diagnosis even on low power. And then there's another area that certainly does not look typical because it does not have those bony trabeculae. So I'm going to show you an image from there, and I'm going to show you an image from somewhere in there. So here's that image from the leftmost fragment of the three fragments. And if you look at this, this looks classic for fibrous dysplasia, right? Bony trabeculae, nothing in terms of osteoblastic rimming, very bland spindle-shaped cells. But take a look at the image from that fragment on the extreme right. It's devoid of bony trabeculae, that's number one. Two, there actually seem to be clusters of giant cells, and this may even raise the possibility of a giant cell tumor of bone. But remember, with the giant cell tumor of bone, the osteoclast type giant cells tend to have more nuclei, and we'll come to that when we talk about giant cell tumors of bone, and they tend to be evenly spread through the lesion. Here we see focal aggregates of these osteoclast type giant cells. And here you go again, these osteoclast type giant cells. You often see areas that look like this with cystic fibrous dysplasia, although you can see it in other examples of fibrous dysplasia. Do not mistake this for a giant cell tumor of bone. And if you don't believe me, here's an example in a rib with cystic areas. Areas like here showed areas that were classic for fibrous dysplasia. So here's another example. This example wasn't particularly cystic, but when you look at this under low power, it's sort of almost devoid. It's all lesional tissue, but it's devoid of those bony trabeculae, except for areas like this. There were areas, however, in this case that we're talking about that were pretty classic for fibrous dysplasia, right? We all agree that's pretty typical for fibrous dysplasia, and so is this, although the trabeculae are somewhat more thickened in this. But the bulk of the lesion looked like this with no bony trabeculae. In fact, I got a frozen with just this tissue on it, and I told the surgeon, I don't quite think this is classic for fibrous dysplasia, but he very well knew what this was because the radiologist had assured him that this was fibrous dysplasia. So the bottom line is you can see areas within zones of fibrous dysplasia that look more fibrous and are relatively devoid of bony trabeculae. So don't let it surprise you as it surprised me. All right, so here's another feature that you may see, and so don't be surprised by this. You can see relatively mature appearing cartilage like this in fibrous dysplasia, and here's a slightly higher power view. This is part of the lesion, not to be mistaken for some sort of a dedifferentiated chondrosarcoma or whatever else horrid diagnosis you can imagine. And at times, as you can see here, here's another example of fibrous dysplasia with cartilage. The cartilage could look fairly cellular. I will point out to you that there is a fair amount of cloning going on in this cartilage. That is multiple nuclei within a single lacunar space, and that's generally a feature of benign disease. And so that should make you, as I often say, make you sleep better at night. And the final point I wanted to touch upon is how much cellularity and how much atypia can you see in fibrous dysplasia? And this example, I've chosen this example because this looks slightly more cellular and slightly more atypical than your classic fibrous dysplasia. And I think we'll come to that when we discuss the differential diagnosis of fibrous dysplasia. All right, so let's move on to another entity, this time osteofibrous dysplasia, which is very much like fibrous dysplasia, but it is like fibrous dysplasia, but very distinctive. And one of the most distinctive features of this neoplasm is that for the most part, and not everyone agrees on this, but for the most part, this lesion is confined to two bones. Here you see it in the tibia. The second bone you see it is in the fibula, and essentially you do not see this outside. So this is a disease of kids, typically in the first or second decade of life, no gender predilection. But as I said, and I'd like to emphasize, that this is a disease found predominantly in the tibia and fibula, and within the tibia, in the proximal and middle third of the tibia. All right, so this is classic osteofibrous dysplasia. It affects the upper and the middle third of the tibia. It tends to have a very sclerotic border, as you see here. It tends to have some mineralization in the lumen, and that makes it look a little like fibrous dysplasia. But the one additional factor that you've got to remember is that this is an intracortical lesion. And although you can well ask me, how are you sure that this is indeed intracortical and there isn't some involvement of the cancellous bone? And for that, you need a CT scan. So same patient, here's the tibia, here's the fibula, and notice it is almost entirely intracortical. And even though it's trying to get out of the bone, there is a shell of cortical bone at the periphery of the lesion. Again, something that should make you sleep better at night. Now again, you can see the same thing on a gross image. Notice the significant sclerosis around the lesion. Notice the lesion is predominantly intracortical, and here's the lesion, right? So an intracortical lesion, and guess what? This lesion was indeed in the tibia. Time for some histology, and this is a very low power view. And if you look at the lesion itself, there are these bony trabeculae surrounded by a relatively hypocellular lesion. This is a fibroosseous lesion, and in this case, osteofibrous dysplasia. So a couple of things to see. Perhaps the most important thing to recognize on low power is that this tumor stops dead at the interface. It does not infiltrate the adjacent cortical bone, and that's an important rule to remember in bone pathology. Benign lesions do not, with minor exceptions, infiltrate the adjacent cortical bone. Another thing that you may or may not see, and it's probably not very well seen here, is that the central portion of the lesion would tend to be more fibrous. The peripheral portion adjacent to the host bone tends to be more bony. Also notice that the bony trabeculae virtually merge with the underlying cortical bone, and that's something you often see in osteofibrous dysplasia. There we go again. Notice that interface of the tumor with the adjacent cortical bone, there is no infiltration. In fact, there is some level of merging of the neoplastic lesional bone with the underlying cortical bone. So an intermediate power of the lesion, and now you see it looks very much like fibrous dysplasia, which is invariably in the differential diagnosis. The one major difference is that osteofibrous dysplasia tends to have a much more prominent osteoblastic rimming. Notice there's a couple of giant cells for the right. These osteoclast type giant cells come along and for the right in a variety of other tumor types, and we'll talk about that when we talk about the differential diagnosis of giant cell tumors of the bone. Now, if you couldn't see those osteoblasts at that magnification, that osteoblastic rimming becomes a lot more prominent on higher power. Again, fibrous dysplasia very rarely has that osteoblastic rimming. It's never as prominent as you see in osteofibrous dysplasia, and that's the feature that you can use to make the difference between the two entities. All right, so time for a differential diagnosis, and I've decided to club the two entities together, although it might make sense to look at them separately, but here goes. So the two entities that you must consider, and here's my approach to these things, right? I always think of the worst. If I'm thinking of a benign diagnosis, my differential diagnosis must and always includes the very worst thing it could be, which generally in bone pathology turns out to be osteosarcoma more often than not. Well, the two entities that you must consider are a well-differentiated adamantinoma, and because these two lesions, that is this and the osteofibrous dysplasia, have this propensity for tibia and fibula, this differential applies only to when you're considering lesions in the tibia and or fibula. The second entity is more broad, although again tibia seems to be a very fairly common site, and this entity I'm talking about is a low-grade central osteosarcoma. All right, so this, doesn't it look a little like osteofibrous dysplasia? In fact, this lesion was from the tibia. The big difference is that it has this epithelial nest that was also positive for keratin, but that cohesive nature clearly tells you that this is an epithelial nest. This is diagnostic for a well-differentiated adamantinoma. Adamantinoma, fairly a tongue twister, at least to me, comes in two flavors, and one of the flavors is a well-differentiated adamantinoma. These nests will not be seen in osteofibrous dysplasia, and therein lies the difference between a well-differentiated adamantinoma shown here and osteofibrous dysplasia. So just to reiterate, both tumors that occur predominantly in the tibia and fibula, one, which is osteofibrous dysplasia, does not show these epithelial aggregates, while well-differentiated adamantinoma is defined by the presence of these epithelial aggregates. And the reason why you want to tell these two apart, because this guy regresses spontaneously, while this guy, if you don't take it out, will recur, although these do not typically metastasize. One major caveat to remember, and remember this guys, if you throw a keratin stain at osteofibrous dysplasia, you will see occasional spindle cells that are positive for keratin. That said, you will not and should not see keratin clusters in osteofibrous dysplasia. The other entity you must consider is an osteosarcoma. In this case, I'm specifically referring to a low-grade central osteosarcoma. This is a tumor more often seen in the jaw and in the tibia. It, by definition, is an intramedullary lesion. This particular lesion actually looks a little circumscribed, and although most lesions could look infiltrative, I've certainly seen my share of less infiltrative lesions, at least radiologically speaking. And the ancillary techniques are genetic for the most part, and most but not all cases of fibrous dysplasia show GNAS mutations, while most but not all cases of low-grade osteosarcoma show MDM2 amplification, which you could use immunohistochemistry as a surrogate marker. However, if you notice, I said most but not all. So if you can identify the mutation or the amplification, you're good. But if you can't, it does not help you one way or the other. Again, just to reiterate the differences between the two entities, the location helps, at least with osteofibrous dysplasia, which is predominantly intracortical. If you have a resection specimen or a nice curettage, the infiltrative nature and the non-infiltrative nature, the infiltrative nature, of course, in an osteosarcoma would help. Remember, benign tumors are well circumscribed, often with a shell of cortical bone, while osteosarcomas tend to be infiltrative. You'll notice that I've kept parosteal osteosarcoma out of this equation. Why? Because they do look very much like low-grade central osteosarcomas. The reason I've kept them out of this discussion, because remember, this is a surface lesion. All three of these entities we're talking about are within the bone, not surface lesions. So even though histologically parosteal osteosarcomas and low-grade central osteosarcomas are fairly similar, the distinction between those two is that parosteal osteosarcoma is a surface lesion, S for surface. Ooh, I'm feeling generous. This is extra time. All right, so this talk ended up being somewhat longer than I intended it to be, and so I put this at the very end just in case you're interested. This is something that you might have to remember for your boards. Fibrous dysplasia is associated with two syndromes, McCune-Albright, which is fibrous dysplasia, endocrinopathies, and cutaneous pigmentation, and the other one, in fact my favorite syndrome, is Mazabrod, which is fibrous dysplasia and intramuscular myxomas. And this can help you remember the fact that most myxomas are also associated with GNAS mutations. So Mazabrod syndrome, GNAS mutations, something to remember. And one final point about fibrous dysplasia, one variant of fibrous dysplasia, and this is referred to as fibrous dysplasia protuberans. And the term protuberance is applied primarily because this lesion explodes beyond the cortical bone and almost forms a mushroom-like lesion on the surface. So you don't typically think of fibrous dysplasia as a surface lesion, with the exception of this entity, fibrous dysplasia protuberans. And here's a histologic image of that entity. Here it's going beyond, shattering the overlying cortical bone and creating this protuberance on the surface of the bone. And that's it. Thanks for listening as always, and subscribe to this YouTube channel if you want to hear anything about GI pathology, bone pathology, or soft tissue pathologies, and please tell your friends as well. Thanks again, and bye-bye.